Hi, my name is Helen Leahy. I'm a clinical nurse specialist in palliative care. This is a presentation discussing the care of a patient at end of life within the intellectual disability services. The particular focus of this presentation is on a patient who is imminently dying amid the COVID-19 pandemic. The learning outcomes we hope to achieve is that we as healthcare professionals can understand the process of dying, that we can recognise the anticipated symptoms that are common at end of life, and that we can identify management strategies for end of life. Dying is a complex process. It involves us having a holistic approach and needing multiple skills to effectively manage a care plan, which promotes the physical comfort of the person amid their functional decline, looks at symptoms they may have, medications they may need, for syringe drivers for example, and ensuring all the while that there is seamless communication between the family and the team, while easing spiritual distress and emotional turmoil. This presentation primarily focuses on the physical aspects of caring for someone who is dying. A follow-up webinar is planned and will attempt to address the other holistic aspects of this care plan. I'm going to start this presentation at the point where a diagnosis of dying has already been made. This is usually following an MDT discussion between doctor, nurse and other healthcare professionals, examining any reversibility in the person's decline, and if there is no reversibility seen, the diagnosis of dying may hold. A care plan is then designed as to how best to manage the person's needs. This diagnosis needs to be communicated to all team members. Importantly, it also needs to be communicated to family members. It needs to be documented clearly. Within your unit, you may need a DNR order to be completed so that the person isn't resuscitated should they decline further. And a ceiling of care needs to be outlined. That being if they're, for example, to spike a temperature again, are they for acute transfer back to one of the hospitals for IV antibiotics or the likes. The patient's current medication list should be assessed, and we should consider stopping all non-essential medications. We should actually consider stopping anything that doesn't focus on the person's comfort and alleviating their symptoms or distress, unless there's a good reason to continue it. Common areas that may require review include things like intravenous or subcut fluids, antibiotics, subcut heparin, insulin, enteral feeding or TPN, and things like venipuncture, blood tests, routine. We should also consider monitoring their vital signs, including their pulse, their blood pressure, their oxygen saturations, and recording things like their fluid balance chart. Patients who are hypoxic at end of life may benefit from supplemental oxygen for comfort reasons. However, if patients are agitated or distressed by oxygen masks or nasal prongs even, we should look at stopping their oxygen and managing their breathlessness with something like an opioid anxiolytic combination instead. I've already mentioned that checking oxygen saturations at end of life is not required. Often it's more burdensome than actually giving any benefit. Things like high flow oxygen systems such as BiPAP or CPAP are often not appropriate for patients at end of life either. We should generally avoid anything unless it gives a clear symptom benefit. We know a lot around the process of dying in a patient with a life-limiting illness, particularly in the cancer population, through data collection. Usually, as the body weakens, we see people getting progressively weaker and becoming more bedbound. There's a deterioration in their overall functional status that's different from their baseline. Their body tends to become stiffer due to immobility, and there's a decreased interaction with others, or they become more withdrawn. There can be less time spent awake and more times asleep, till eventually they're unresponsive and there's no waking time. The person may have some difficulty swallowing. There may be a decreased intake of food and fluids. They might have trouble taking their oral medications. As the body weakens, the peripheries can become quite cold as the blood circulation is diverted to central processes, so their hands and their feet can be quite cool to touch. They may have an irregular heartbeat, which can be due to metabolic or vascular changes. In appearance, they can look quite gaunt. They can be pale or even grey in colour. Their skin may be marking easily or have a mottled experience. and they may have a pinched white appearance around their nose. Breathing patterns can change quite a bit. Patterns can fluctuate from one to the other and in no particular order. They may have a pattern of intermittent breathing, which is common at end of life, something called chain stoking. The control of your breathing is driven by the buildup of carbon dioxide in the system. When the level of carbon dioxide is low, there's no drive to take a breath, and so there may be long, extended gaps without breathing. Then, when the carbon dioxide builds up in the system, this will eventually cause the body to take several big breaths to expel the carbon dioxide. They may have shallow, irregular breathing even, or seem like they're panting. Or sometimes we hear involuntary sighing on exhalation, or other breathing patterns may be noted. In the context of a COVID-19 positive patient, the previously described process of dying may differ. The potential to become acutely unwell and deteriorate rapidly over the course of a few hours, usually due to symptoms of respiratory distress and delirium leading to death, is a significant risk for COVID-19 positive patients. It is essential that we anticipate symptoms at end of life. A planned approach is so important. We only get one shot to get this as right as we can do. All prescribing at end of life is anticipatory. The correct dose of any medication is the lowest possible dose that achieves the desired effect, but there's a wide variation in the doses of drugs needed. Breakthrough medication, or the as required medications, must also be prescribed. Next, we'll look at the symptoms that we should expect when somebody is dying, how we'll recognise those symptoms, and how best we can try to control and manage these symptoms. Respiratory distress or respiratory symptoms is common at end of life and has a high prevalence in COVID-19 positive patients. Patients may experience shortness of breath, difficulty in breathing or dyspnea, cough, and noisy chest secretions. The reference at the end of this slide, the Palliative Care Guidelines, is an NHS and HSE endorsed one-page document useful for looking at the management of severe breathlessness in dying patients with COVID-19. Respiratory distress is a subjective experience if the patient is able to report it for themselves. If the person is unresponsive, you may notice that they have rapid breathing, or what's known as tachypneic. They may be using their accessory muscles with each breath, so their shoulders may be moving, their abdominal muscles may be working hard. Their breathing may appear laboured. They may be groaning even, or sighing with breaths. They may be making attempts to cough, but they're so weak and unresponsive that they're unable to expectorate or clear any secretions from their upper airways. They may have noisy respiratory secretions. Even a small amount of secretions near the vocal cords can create a really distressing loud sound when amplified by the thorax. There may be pooling of secretions in their mouth or in their upper airways. As a reminder, for AGP and PPE guidance, refer to HSE guidelines. For the non-pharmacological management of respiratory distress, we look at things like positioning, sometimes elevating the head of the bed and having the patient as upright as tolerated, allowing gravity and postural drainage may help. Quite often, when a patient is dying, we have them lying on their side and rotate them from side to side. This appears to be more comfortable, but quite often sitting them more upright may have better benefit if they're chesty. It's also worth noting if they have a preferred or a better side. This may well be that you've noticed that on one particular side they sound less chesty than on the other, and this may be the side to use more often. Frequent mouth care is important for the patient's comfort, for clearing any pooling of secretions, and for controlling any odour that may gather. It's not always possible to ease the noise of somebody being chesty, so we might need to look at actually masking the noise, playing some music in the room or the TV. We should not use fans while COVID-19 is a risk. Suctioning is unlikely to be successful. It has all the associated infection risks of an aerosol generating procedure in COVID-19 cases. It It may even create pain or reflex coughing, gagging, and/or choking in the patient. And it can often worsen noisy breathing by causing a reactive airway oedema or irritating the respiratory mucosa, resulting in further production of secretions. For the pharmacological management of respiratory distress, individual assessment is essential, and reassessment is as important. We sometimes use an opioid for breathlessness and/or for cough, for example, something like morphine sulfate. An anxiolytic sedative such as midazolam may also benefit, as would an antisecretory such as hyoscine butyl bromide, commonly known as buscopan, or hyoscine hydrobromide. Diuretics tend to be of limited effect unless the person has congestive cardiac failure or proven fluid overload. To use diuretics, the person is likely to need a catheter so that you can observe their output, which will present and also prevent retention. You observe the noise of their chestiness for effect, and if effective, the diuretic could be repeated. Another one-page document from Palliative Care Guidelines endorsed by the NHS and HSE is anticipatory prescribing in the last hours of days or life, and this covers some of these medications and suggested doses also. Evidence shows that medications are most effective when started at an early stage. Also shows that no antisecretory medication is consistently better than another. The choice of the drug should remain with prescriber on an individual assessment basis, and regularly assess the patient's clinical situation and response to any medication administered. Pyrexia is another common symptom at end of life, particularly in the COVID-19 population. Once again, for AGP and PPE guidance, refer to the HSE guidelines. To recognise pyrexia, the patient may have a high flushed red colour. They may be sweaty or clammy, and may even be shivering or having a rigor. Their temperature is greater than 38 degrees Celsius. For the non-pharmacological management of a pyrexia, comfort measures such as a cool cloth to the forehead might help. Ventilate the room if it's appropriate by opening the window or the door. Pharmacological management is something like 1 gram of paracetamol. It might be in suppository form, so per rectum, as needed, or up to QDS. This may benefit. Pain is the next symptom we'll look at. In the intellectual disability population, pain is sometimes anything altered in a behavioural pattern. Quite often it's around knowing your patient, knowing what the baseline normal behavioural pattern is, and knowing what's out of that. If they appear more agitated or more withdrawn, is pain the cause for this? They may be more vocal. There may be groaning if they're unresponsive, grimacing or frowning. There may be crying or sighing even. Sometimes there can be a groaning or a sighing that can be involuntary when somebody is unresponsive at the end of life. But if unsure as to what the cause of it is, and if in doubt as to whether pain is a feature, we should treat this as a pain. Again, if the patient is able to tell us or report, then their pain is a subjective experience. Pain is what the patient says it is. The Abbey Pain Scale is a useful tool for monitoring pain and recognising and assessing pain in somebody who is unable to tell us or who is unresponsive. Recognising known preferences is important in trying to manage somebody's pain at end of life. Like chestiness, sometimes we see that patients are more comfortable when lying on one particular side. If you know that somebody has always liked to sleep on their left side or their right side, that may be their preferred side now. We should always consider new pains as being an issue as well. They may have new pressure points. They may have a distended bladder in urinary retention. They may be constipated and have a distended abdomen, causing pain to those sites. The pharmacological management of pain starts with us trying to select the appropriate route of analgesic delivery. If the person is still able for oral medications and able to swallow them, this may be the preferred route for the time being. But if unresponsive, subcutaneous is the preferred route. Using an opioid is common at end of life, with something like morphine sulfate. We should consider PRN analgesia pre-movement or turning or any kind of exertion if that unsettles the person and seems to cause pain. The choice of opioid being used is a clinical judgment and based on the individual's history, their comorbidities, their tolerance and availability. Delirium or agitation is another common symptom at end of life, and particularly in the COVID-19 population. It may present with the patient becoming confused, increased agitation, hallucinations, again an altered behavioural pattern, anything outside of the normal baseline. There may be aggression, they may even be quieter or withdrawn. There might be fluctuating emotional patterns. Knowing the patient's character and their usual behaviours will usually help to identify the abnormal patterns. The non-pharmacological support that we can do for someone who has delirium are things like looking at the environment. Are they used to the environment being noisy and now it's too quiet, or the other way around? Is the lighting wrong? Do they like the lights off or on normally? What's their preferred music choice to have in the background? Do they normally like people reading to them or doing activities around them? Things that I'm sure in an intellectual disability setting you know all too well. Using known or individual calming measures that have worked before, or calming presence even of somebody that usually knows the patient well and has a good influence on. Trying to keep a routine going. Trying to orientate as frequently as possible, particularly if they're responsive. Giving explanations and reassuring again if they're able to understand. Courtesy and respect, going without saying really. Patient safety and adhering to hospital policies in kind of risk of falls. Having a family or a carer member presence at the bedside might help to calm the person. And constant communication. The pharmacological management of somebody with delirium again depends on an individual assessment, which is essential for the selection and the doses of medication. Using things like anxiolytic sedatives such as midazolam, levomethylpromazine or haloperidol may be beneficial. Again, I would refer to the reference of the anticipatory prescribing in the last hours of days or life, the HSE and NHS endorsed one-page document, which is referenced at the end of this talk as well. Both levomethylpromazine and haloperidol also have a potent antiemetic effects, so may be useful if nausea is also a problem. A common practice at end of life is to deliver the subcutaneous medications mentioned via a continuous subcutaneous infusion device or a syringe driver at end of life. This is not strictly necessary all of the time. If an infusion device is not available or healthcare professionals are not feeling confident or competent with their use of the device, it is possible to just administer the total 24-hour dose in equal divided amounts every 4 hours, and then using PRN medications in the normal way. Advice can be obtained via the specialist palliative care team on this practice. There's also another useful one-page document endorsed by the NHS and HSE entitled Prescribing Regular Subcutaneous Medications in the Last Hours or Days of Life when a Syringe Pump is not available. This is referenced at the end of the slide and again at the end of the talk. It's important to remember that if the patient's condition unexpectedly improves, these measures must be revised and the care plan renewed. Ongoing nursing assessment of the patient throughout the dying phase is essential. Promoting their comfort at all times, making sure that their symptoms are as controlled as possible, they're being reassessed and they're being monitored. Pressure care is important. If death is imminent in the next number of hours, repositioning may be for comfort only. We need to consider a pressure relieving mattress and watching their skin integrity, but it may not be necessary to keep turning them every 2 hours or whatever the normal protocol is. Bowel care is also important, making sure that the patient is free from any bowel problems causing distress. At the same time, if their bowels haven't moved for a number of days, it may not be appropriate to intervene with PR intervention if they're not distressed. Their urinary status is important to assess, making sure they have the appropriate aids, Maybe they need incontinent wear as opposed to needing to change the full bed every time they've been incontinent. Or maybe even a catheter would benefit from the effort of changing them when they are incontinent, or to measure their output. Keeping their eyes, their mouth, their lips clean and moist is essential for comfort. Sometimes if family members are there at the bedside, they can get involved in these tasks, and it's important for them to be involved in caring for their loved one as well. Supporting their emotional and psychological needs, supporting their spiritual, religious and cultural needs. Communicating with family so that they're as prepared as possible for the patient's death. Sometimes just talking them through the process of dying even can be helpful. And the process of what arrangements need to be made after the person has died. When we talk about family in palliative care, we talk about people who have been closest to that patient in experience rather than just blood ties. Sometimes in an intellectual disability setting, healthcare professionals are another arm of the patient's family, and also may be distressed at the patient's deterioration and their impending death and need extra support in that. Arranging a session of reflection or debriefing, or just sitting for a few minutes, is vital for our development and growth as healthcare professionals after a resident has died. It's also vital for our own self-care, learning and nurturing, and helps give us the strength to move on to the next bedside and deliver the excellent care that we strive to continue. Caring for somebody at end of life has a holistic approach. We've spoken about some of the physical aspects of caring for somebody imminently dying. The other aspects include the spiritual side, the psychological side, and the social minding of somebody at end of life. Effective communication and teamwork are some of the things that can help in the other areas as well. We have a follow-up webinar to take your questions on Thursday the 16th of April 2020. This is at 2:30, and we would hope that your questions will encompass all of the holistic care aspects needed for minding somebody at end of life. Thank you for listening. The references that I've mentioned throughout the talk appear on the next slide just to end the presentation, and we'll hear from you with your questions next Thursday the 16th of April at 2:30, myself and other members of the multidisciplinary team. Thank you. For further information, please refer to the Marymount website on www.marymount.ie. There's a healthcare professionals hub there which has a wide range of variety of up-to-date materials, including the one-page documents that are referenced throughout the talk.